Hello, everyone. Thank you for attending today's discussion, Bracing for Impact, the top risk areas for health plans and providers to watch in 2021. I'm Linda Hand, Prealize Health CEO, and I'm really happy to have you here with us today. I'm going to be moderating the webinar, but just a few technical notes before we get started. The discussion is being recorded and will be available on demand within a few days of the event. We will send you an email when it's available. We're going to follow the discussion with a Q&A session, so please submit your questions using the question and answers tab. And also, if you encounter any technical problems during the event, you can describe the problem in the question and answers tab, and our team is standing by to help. So the panelists, who will introduce themselves in a moment, are joining us to discuss the findings from our recent 2021 State of Health report, which identifies the key conditions payers and providers should proactively address in 2021, and that's based on healthcare utilization in 2020, and particularly the significant healthcare utilization declines that occurred due to the COVID-19 pandemic. So to identify those top conditions to watch, we analyzed claims data from more than 580,000 commercial, Medicare, and Medicaid patients between March and August of 2020. We then applied over 50 machine learning models built into the Prealize platform in order to project diagnostic and utilization trends for 2021. So while the report's findings are meant to provide the healthcare industry with a look at some of the biggest trends to watch for 2021, this is work that we do on an ongoing basis every day for plans and provider organizations. We're forecasting based on their own patient populations, which makes the results very accurate, actionable, and very relevant to the population. So our machine learning models access over 30 clinical drivers of future healthcare utilization, and we predict a patient's risk for being diagnosed, with a clinical condition or with needing a clinical procedure up to 18 months before a claim is filed. Based on 2020 care deferrals, our 2021 predictions include an 18% increase in patients diagnosed with ischemic heart disease and a 14% increase in patients diagnosed with congestive heart failure, a 23% increase in cancer diagnoses, and a 112% increase in patients diagnosed with fractures. So let's dive into the discussion, but first I want to start with a brief round of introductions by the panelists. And I'll start with how you appear on my screen. Could you please share a bit about your background and your current position? I'll start with Mark.
So I'm Mark Smith. I'm a clinical professor of medicine at UCSF. Spent 17 years as the founding president and CEO of the California Healthcare Foundation. And since I retired from that, I've spent a lot of my time working co-chairing with Mark McClellan, an effort by CMS to accelerate the progress for value-based care payment methods. Member of the board of Prealize.
Right. Ron?
Hey there, I'm Ron Paulus. I am currently an executive in residence with private equity firm General Catalyst. I also have an advisory services company, RAPMD Strategic Advisors. Most recently, prior to that, I was the CEO of Mission Health, and I am an advisor to Prealize.
All right. Gordon.
Thank you, Linda. I'm Gordon Norman. I'm a family physician and population health consultant who started my professional life in the Northeast as a rural family doc, and then pivoted mid-career to the business side with executive roles at Pacific Air Health Plan, Alere Health, Geisinger spinoff XG Health Solutions, Willis Towers Watson, and currently my own consulting company, Population Health Solutions. You may or may not know that the original Prealize derived from Stanford University, and I also have deep roots in that community after obtaining 3 degrees at Stanford, and a lot of respect for the founders of Prealize, and have been pleased to work with Prealize for the past 6 months as their chief medical officer.
Great, thank you very much, an impressive panel. So as I noted earlier, we recently released the 2021 State of Health Bracing for Impact report. So I'd like to dive into the findings. The report found that COVID-19 related utilization declines in 2020 are going to lead to escalating health conditions and costs in 2021. So as we enter 2021, how would you each characterize the environment that payers and providers are going to face over the coming months?
Well, I guess I'd start with uncertainty. Not only do we not know for sure how this pandemic is going to proceed, but we don't know exactly what the impact of the vaccination rollout is going to be and what the impact of these newly discovered strains are going to be. And so I think while perhaps a couple of months ago, people were seeing themselves as getting back to normal and people resumed elective surgeries and the rest, it's not at all clear to me that that's going to be the case. And I think it's going to be several months and tragically perhaps longer before we really get anything back to what we would think of as normal utilization.
Yeah, I agree with that, Mark. And at the same time, there are certain aspects of utilization that are going to come no matter how you slice it because of the severity of the disease. I saw the Avalier report that cancer E&M codes were down 70% during the most recent period. And that is unfortunately not because people don't have cancer, right? And so there is a pent-up demand that will be coming at some point. And I think part of what's so important is the ability to forecast what's likely to come from within your own local community, because every community is different.
I would add to what Mark and Ron have said to suggest there's going to be a moderate degree of chaos for a while as the vaccinations spread and people develop confidence in seeking care again. I think a lot of them will rush to backfill that deferred care. And so life is not going to return to normal anytime soon, I think, for actually patients or providers or health plans. I think it'll be essential for plans and providers to coordinate who's doing what in sorting this out. I think there'll need to be continued leverage of virtual health, which was so dramatically expanded during the pandemic to augment face-to-face care and deploy as many of the diverse resources of primary care medical homes and PCP practices as possible to accommodate the needed overdue screening and outreach to high-risk patients.
Great. So let's home in on the three conditions that we found that will have a significant increase in diagnoses this year: cancer, cardiac conditions, and fractures. What actions do you think payers and providers should be taking given this information?
Yeah, I'll start. I think the core thematic from my perspective is around figuring out who you have within your population and ways that you can meet them where they are. It's unrealistic to think that these patients are going to be coming in to doctors' offices and hospital settings for screenings and other things when they're essentially afraid of what might happen to them. And so the leveraging virtual care platforms, the kinds of colonoscopy substitutions like the stool DNA test, all of those kinds of things need to be pushed up and maximized in terms of the priority to be able to manage through this interim phase, assuming we eventually get back to some form of normal whenever that may come.
I also think it puts a premium on being proactive. As Ron said, it's not like people stopped getting cancer in the last year, but if they delay screening or seeking care, it's likely that they'll present at a later stage. A later stage means worse outcomes, means more expense. It's not like people stopped having congestive heart failure, but if they're not well controlled, then they will likely have worse morbidity and again, more expense. And so there's a premium in trying to figure out who has not showed up for the kinds of things that they would have showed up for had they been able to, and reaching out proactively to prevent this deferral of care from leading to both worse consequences for them clinically and for payers and providers economically.
I concur with Mark about the proactivity, but each of these three conditions will require a somewhat different approach by providers to how they go about this. For instance, in cancer, I think the overdue evidence-based periodic screening is going to be of utmost importance for outreach because many will be overdue. For cardiac, I think it's probably overdue visits for risk factor optimization. So a lot of people are going to need rechecks for that element of their risk factor management. Fractures, unless the provider happens to be in the acute care setting, probably won't be dealt with on Zoom or in the office in the acute phase, but subsequently may require PT, further rehab, and depending on the individual, things like gait training, et cetera, for maximal return of function. So I think this is going to stretch the full capability of providers to deal with just these 3 diagnoses.
Yeah, I would just add one other thing that I think payers need to think about their relationships with in-home and out of the hospital care providers, companies like CityBlock or Landmark or Dispatch that are, able to get out and get into the home and to fill the gap that traditional doctors' offices, waiting for patients to be seen, are not doing.
You mentioned virtual care and the uprise of that and the increase in that. And Mark, when we were talking earlier, you also made some really good points about how the landscape is changing with respect to competition and geographies. Maybe you can comment on that.
Well, you can look at almost any segment, and because of the explosion of virtual care, there are now competitors, or in some cases publicly traded or better funded competitors than there were a year ago. And so there are a number of telemedicine companies that have gone public, now well-funded, struck new relationships with payers and employers. There's a dramatic growth in the number of startups that are taking advantage of both patients and providers' newfound comfort with and desire to use the convenience of virtual care. I'll also point out that, as Rob was saying, if you think about how much of care has been forced into the virtual world that will probably never come back. Think about wound care. Think about pre-op and post-op care. A lot of things that we just kind of habitually did in the office, we've learned we actually don't have to do in the office. And so I think a lot of that will migrate to a post-pandemic state in which there's much more of a hybrid practice for almost every specialty. Even if your specialty involves direct contact and even piercing flesh, there's aspects of that care that before that moment and after that moment don't have to be done in person, can be done more safely, more conveniently, and more economically with some sort of hybrid practice. I also think it's meant that hospitals that thought they had a monopoly in a given area or that their market was a given area have discovered, turns out their market is any place anybody has an internet connection. And so I think even institutions that have had a relative market presence that was dominant may find new competitors showing up, leveraging their brands from the experience of the rapid and very dramatic increase in virtual care that every academic medical center and big hospital system has seen in the course of the last year.
The economics were really kind of shuffled up a little bit with COVID, value-based care versus fee-for-service. Maybe there are some things to think about with respect to these conditions and care in 2021 with respect to that.
Yeah, I think there are a lot of providers, whether they be physician groups or hospital systems or what have you, that would have been appreciative of a capitation stream during the peaks of the COVID pandemic. And I think the intersection of that reality with the increasing virtualization of care and the democratization of care out and about outside of fixed cost infrastructure facilities like hospitals creates the nidus of opportunity. Now, we'll need the incoming Biden administration to facilitate regulatory frameworks and reimbursement paradigms that enable that to continue. Part of the big push in virtual was the ability to get paid, which has been an ongoing barrier. There are other barriers like workflow optimization and the ability for elderly and other people to actually get online in their homes effectively at the right time and right place. But the policy framework is an important part of this discussion as well.
Absolutely. Any other thoughts on policy, given the change in administration and where we need to go, or things that changed in 2020 that may be undone in 2021?
Well, as Ron said, look, there's a whole range of things from payment parity to the capacity to get paid for virtual care without having previously established an in-person relationship, to waiver of state licensure, to scope of practice. There's a whole variety of things that were waived that created this revolution in telemedicine. Like all revolutions, it spawned a counter-revolution that's waiting around the corner to flex its muscles when the pandemic is over or recedes. I'm not smart enough to know how it's going to turn out, but I think the longer the pandemic goes, the more likely it is that at least some of these things will remain in place. But there's no question that there will be big fights about them as care gets safer. And that, I think, is one of the big unknowns in terms of the headwinds that telemedicine has faced.
Great. Were there other comments on that?
I agree with all of Mark's points, and I would just add emphasis on the reimbursement side of virtual care, and not just telemedicine, but in-home monitoring and other kinds of supportive care features. And this licensing scope of practice issue has got to get addressed at some point, because the idea that I, as a physician, although I will say my wife's very clear, you're not a real doctor anymore, don't touch the kids. But for those doctors, that are still practicing, the idea of having to get 50 licenses for 50 states on a virtual platform is literally nonsensical.
So we can't explore all the report's findings during this time today, but since you all provided some analysis for the report, I'm sort of wondering, is there like one more report finding that you think the attendees should be aware of, or other predictions that you might have for 2021?
Yeah, one area that I think is getting short shrift, and it's one of those areas that we all experience and that sometimes is an uncomfortable discussion topic, is around obesity. Right, we knew that we have an obesity epidemic in America, approaching over half of Americans being obese. If you ever want to have an interesting day, go through the BRFSSS slide set where it shows the obesification of America year by year by year by year, and you see the color change on the U.S. map and the shift in the states. But people joke about the COVID-15, but it's not really a joke. This lack of mobility that we've had, being at home, which I think, I can't prove, but I think also increases the fracture risk from people being immobile and then, moving around and so forth. So obesity and all of the sequelae of obesity, I think, are going to be another really important issue, and behooves insurers and employers to be focused on outreach and proactivity.
I'd like to add a cautionary note about our findings that behavioral health conditions are not expected to rise significantly. I'm concerned that we may be facing a significant volume of post-pandemic stress disorder, a new PTSD analog. As a novel condition, I wouldn't expect our machine learning algorithms to identify this yet, but some psychiatrists are already voicing concern based on the rise of depression, anxiety, and some PTSD symptoms during the pandemic that may not be extinguished once we have widespread vaccination and some degree of herd immunity. So I think providers need to remain alert to this possibility.
Any other thoughts?
Just share one other point. I do think there's an opportunity for payers to increase their interaction and collaboration with employers, right? So, most players have, a mix of fully insured business and back office outsourced, TPA business. And employers are likely to be maintaining contact with at least in those industries where people are still employed. I recognize the horrific transition in folks who've lost their jobs, but
Oh. You lost your audio, Ron. Okay, not sure. You can come back. Gordon, I think you had some thoughts around COPD. I think we had some thoughts around substance abuse as well. Maybe the other panelists can take up those topics.
Thanks, Linda. In addition to newly diagnosed COPD, I think there are going to be some established COPD patients who were former smokers, but quit along the way, who may have relapsed during the stress of coping with the pandemic. So it seems to me screening the COPD patient population for those relapses and offering current treatment options may be quite appropriate.
Mm-hmm. Mm-hmm.
I wanted to say a word, if I could, Linda, about the question of equity, because obviously this past year has been a tumultuous one in which the pandemic, which laid bare a lot of fault lines in terms of inequities in healthcare and in social determinants of healthcare and of risk of infection, coincided with the Black Lives Matter movement and this huge social upheaval around equity, which many, many institutions, including virtually every provider and every plan that I know of, has spoken out about it and is now trying to pursue an equity agenda. And there are all new sorts of positions and appointments of people who have charge of that agenda. The point I want to make here is that I don't think this requires the development of a whole new portfolio of quality measures. I think the place where people can start is to pick the 1 or 2 or 3 most important quality measures in the work that they do, and then analyze them by the axes that we know have inequities embedded within them. And so if you are measuring your hospital readmission rates, you should analyze them by race. If you are measuring your patient satisfaction scores or CAP questions about being treated with dignity and respect, you should analyze them by primary language. If you are analyzing satisfaction with pain control or net promoter scores, you should analyze them by gender or by ethnicity, because I think there's a rich soil there for opportunities for improvement without the necessity to dream up some new measure of equity. I think the measures of equity are right in front of us. Pick whatever you think is important to your operation, to your hospital, to your health plan's interaction with its enrollees, with your employees, with your department or your patients, and say, what's a really good measure of our quality of care? And then let's look at this by an axis that we know contains inequity within them. I think that's the place to start. And I think there are tools that Prealize and others have that can help people pick those things apart and predict where there'll be opportunities for improvement.
Mm-hmm.
Just to tag,
measuring, go ahead.
Sorry, Linda. Just to tag on to Mark's notion there, I think predictive modeling that incorporates racial and ethnic information, as well as social determinants of health, can aid enormously in the identification of those at increased risk in a more equitable fashion than many of the prevailing prediction methods that ignore these important contributors to risk.
Yeah, I would add my voice to both of those comments. And, when you think about where we are relative to social determinants and the fact that people are understanding now just how critically important that is, and just choose food insecurity, right? This pandemic has increased the number of people that are food insecure by an order of magnitude that we haven't seen since the Great Depression. So if you're not looking at social determinants and you're not including those in your analytic forecasts, in your outreach, and your proactive design of care management and other strategies, there's no way you're going to make the impact that you need to do, which to me is why generalizations about what's happening nationally are great, but analyzing your own local information for your specific subset of patients that you have and that have whatever demographic and associated social determinant characteristics they have is so critically important for where we are.
Let me make one more point about that if I can. In the early days of the pandemic, in February and March and April, when it was already apparent that there were real discrepancies and disparities in who was getting sick, who was being hospitalized, who was being intubated, who was dying, the kind of easy, facile answer that one often heard, particularly in the lay press, was, and from some politicians, was, oh, these are people with pre-existing conditions. These are people who have diabetes, or they have COPD, or they have some other pre-existing medical condition. And of course, some of that's true, but we now know that actually it has much more to do with where you work and how you get to work and where you live and how dense your household is and whether you can work from home, as most of the people on this Zoom have been able to do, or whether your job is such that you are shoulder to shoulder with 50 other people packing pork products or picking avocados or doing the kinds of work that puts you at risk for spread. And so there's no clearer example of how complicated the relationship between people's social circumstance and their health outcomes is. Now, that's not something that everybody can do everything about, but it is a very stark reminder that our notion of what it is that leads to good or ill health is really quite constipated, quite constricted, if we think of it as BMI and hemoglobin A1C. And it leads everyone, plans, providers, anybody who cares about the health of the population, to think deeply about what the factors are that contribute to differences in health and what each of us in our various settings might do to ameliorate those things.
Yeah, you know, Mark, not to pile on that, but we can also see it right now in things that we do have more control over. Right now, white Americans are being vaccinated at a rate 2.5 times non-white Americans. And there's lots of reasons, right? There's fears and belief systems and other factors, but our job as providers or payers is not to, whine about that, but is to do something about it. And so, focusing on the vaccination strategy and reaching these populations, not everybody can come to the forum in LA to sit in a car for 2.5 hours, that's over 65 and wait for a vaccination. They can't do it. They don't have transportation, back to the issue of social determinants. So if I'm running a plan, which I'm not, so take this with a boulder of salt, but I'm trying to figure out how do I get the vaccine to those people that most need it and who are most likely not to get it.
There have been a lot of problems and challenges with the vaccine rollout. So I guess let's kind of roll with this question around what should we be doing to assist with that, and how do we get patients and facilities ready?
To continue with Ron's point, I would expect the expanded scope of a federal role in what's going to occur in COVID vaccination and beyond will hopefully also include a national registry so providers can tell which of their patients have had vaccination and which have not, in order to make their outreach much more efficient. Lacking that, I think they're going to have a big job on their hands. Obviously, when they identified at-risk patients who have not, I think they can play an important role as respected health authorities to dispel misinformation and unwarranted fears about vaccination risks. But I think it's going to take proactive outreach, particularly to those patients at higher risk for COVID-19 who have not had or presented for vaccination.
One of the other things we haven't talked about is the post-acute consequences of COVID-19, which we're just beginning to understand, these long haulers. But we know that in college-age athletes who've been infected, there's a serious incidence of cardiomyopathy that may have been subclinical, but we don't know what it will do in the future. There are issues with people's neurological and other systems that are affected by the virus, whose complications and implications for their future health, future expenditures, and future care needs, we're just beginning to understand. And one of the kind of interesting and tragic and yet fascinating questions, I think, over the course of the next year is, just how big is this population, and where are the deficits that remain, and how closely do we need to follow people and look after them in the aftermath of their being infected? Another important question that we will just take a while for us to figure out.
We talked about the fact that not everybody has a provider, so how to really think about that. Earlier, proactive outreach to actually vaccinate people who are either at high risk or whatever, using predictive analytics is one way to do that. But, you know, whose responsibility and how do we coordinate more of that? Ron, you were going to say something?
Yeah, and not only does not everyone have a provider, people who are listed as having provider may have zero relationship with that person. So it's even a bigger population of people that really don't have a relationship than we might otherwise know. So to me, it comes back to an intersection of the payer and the employer for the employed subset of people, because we've got to track these folks down. And that's why, you know, getting into the home, thinking about how to do those kinds of things is so critically important.
Fortunately, Ron, for those lacking a physician relationship, there will be increasing numbers of public health sites, hospitals, pharmacies that are offering vaccination for the general public. While that's not necessarily top-down driven or very systematically organized community by community, I think these things will continue to spring up, although all are dependent on a rising volume of vaccine itself. So hopefully that is attended to as well.
Yeah, and also dependent upon transportation, right? So you wonder about facilitating Lyft, Uber, rides to vaccine sites, and other kinds of things that can, you know, come back around to these social determinant questions.
Yeah, I was going to kind of marry that health equity dialogue with some of your early comments around alternative care, virtual health, the other sort of modes of last mile. You know, can we actually solve, you know, kind of kill two birds with one stone, if you will, and really hit on some of those access, transportation, et cetera, with these alternative modes of care?
I also think there's room for something that I actually haven't seen yet. Hopefully it's going on someplace else, which is a little more provider to provider and payer to payer collaboration in local areas. I'll give you an example. I live in Oakland, California. There are 3 ways that people get their vaccines in Alameda County, which is where Oakland is. One is that Kaiser Permanente, which is obviously both a payer and a provider, has been allocated vaccine. Sutter Health, which is mainly a provider, a little bit of payerish, a payerish characteristic, but mainly a provider, has been allocated vaccine. And then the public health department has been allocated vaccine. Well, what if you're Blue Cross or Blue Shield and don't get your care from Sutter? Or what about, so from my standpoint, I haven't seen, but I would think it would be an important time right now, since rolling out this vaccine stuff is so urgent, particularly given the mutations that are occurring, that there be some more collaboration and discussion across these lines of payers to each other and providers with payers in a local area to try to coordinate this stuff. I don't know if that's happening. I know the rollout in Alameda County is chaotic, would be a generous description of how it's going. And of course, one of the things we find is that this varies so dramatically from one state and even one county to another. So it does strike me that if you're sitting in a health plan that has 2 or 3 main competitors in your region, it might be time for you to talk with them about how you might together coordinate with public health and other authorities to try to make sure that this vaccination rollout happens as efficiently as possible.
Mark, your remark caused me to think about how often we criticize the dismal state of interoperability of electronic health records, but arguably the state of operational interoperability between multiple payers, health systems, and providers is even more in need of improvement. And I think maybe a pandemic and post-pandemic challenges would be enough to cause some progress on that front.
Hey, Linda, can I raise a different topic?
Sure.
So, you know, I've just been thinking back to Mark's comment from the beginning about, quote, the new normal. And the reality is, I think at least we're in agreement that we don't know when the new normal is. And when you think about the challenging position that puts payers in, you know, how do you rate set going forward? What base year do you use? You know, are you going to model off of 2019? Why do you think 2019 is going to be the same as 2021? You're left in a no man's land where the only thing you could realistically do is to analyze as you go, right? So you've got to continually be feeding new data into whatever models you're using, updating those, and using them to deploy where you are. We've never had a more rapidly shifting territory where relying on what it used to be may be the least accurate thing you could ever do. And so I think one of the things, however, you know, plans are going to do it, is they've got to change their forecasting methodologies so that they can stay current, you know, month by month, quarter by quarter, and not be reliant on these old data sets that don't really apply to whatever future we're going to have.
Yeah, yeah. Our experience has been so atypical. Looking back is not going to be sufficient, right?
Well,
No,
I also,
nor-
I also think that has implications for providers, because as a teacher of mine once said, if you change your business plan, everybody you do business with has to change their business plan too. And so to the extent that contracts and relationships are built on a set of forecasts, and people's gain share or penalties are based on a set of what would have otherwise been, I'm not sure that anyone is very confident about that. And so the same kind of need to ingest data, to analyze it quickly, to do kind of rolling adjustments as you go that you pointed out for payers, also I think is true for anyone who does business with payers in contracts that rely on historical data and projections and kind of assumptions about what would have been. So for the next year, 2, 3, I think we'll all be dealing with a situation in which your capacity to acquire, ingest, analyze, and use data to do kind of rolling adjustments of your expectations will be particularly important.
I would add emphasis to the rolling aspect you mentioned, Mark, because I've already seen some simplistic thinking in the healthcare leadership world that just as we had a deficit of utilization related to COVID in 2020, we'll see a somewhat mirror image backfill of that underutilization in 2021. And then presumably thereafter, we come back to something akin to baseline. But that to me assumes that COVID is a one and done phenomenon in our lives, which is certainly not evident at this point in time. It ignores the long haulers that have already been mentioned, who will continue to have an aberrant influence on utilization trends. So I think we're going to have to stay nimble and scrutinize the data on an ongoing basis for some time to come to reset normative expectations about prediction of cost.
It also assumes that we're going back to the same style of practice, mode of practice, place of practice, ex ante. And my own sense is you will go back there somewhere, and depending on how strong the counter-revolution is, some of the transition to a new mode of care will be blunted, but it's impossible for me to imagine that people would want to go back to wasting their time to drive across town to get a piece of information, now that they understand that they don't have to do so. Any more than any of us would go back to a bank that required that you come in before 3 o'clock on Friday to do business with them. It's just people, and it's true for providers and patients alike. It's like once you get a taste of what this might be, yes, you'd like to see your provider in person, but I work in a clinic whose patients are kind of the poster children for the digital divide. These are not rich people. They're not tech savvy people. They're not people with lots of resources. And we pivoted the HIV clinic to virtual care in March and have been asking our patients, when we can go back to seeing people in person, would you like to have at least some of your care continue in this fashion? And overwhelming majorities have said yes. So I can't believe that that's not also true for a commercial population that is more tech savvy, that's been doing their work and their kids' work and everything else by Zoom for the last year or so. To tell them, yeah, we're going to go back to doing things the way we used to. It's like, what are you, nuts? So I think all of those things will need to be taken into account. I don't think we're going to go back to the ex-ante baseline.
Although I think those parents are ready to go back for the kids, Mark.
Yes, they are, right.
For sure. I want to give a quick reminder to the audience that you can ask questions using the Q&A button there. Let's see. So in a perfect world, physicians, care coordinators, and clinical leaders would have unlimited resources to reach out to all patients. And we've talked about the need for vaccines, the need for prioritizing outreach to that. We've talked about health equity. We've talked about these rising conditions that we've predicted that are gonna, if it's a boomerang or post, additional COVID insurgence, how can organizations really harness their existing resources more efficiently to really think about that outreach?
Yeah, I'll start if that's okay, and I'll incorporate the question from Dean about whether payers are willing to adopt different cost projection strategies, and whether this is a time to look at AI and machine learning strategies. And without hopefully being too self-serving for Prealize, right? That's the whole point of what Prealize does, and I think the adoption of Prealize within the payer community and the provider community to a lesser extent is evidence that can be done. And why is it being done? It's being done because there aren't unlimited resources, and you have to know who it is that you actually need to reach out to. And not only who could benefit from being reached out to, but who is likely to be receptive and have an impact from that outreach. And that's the only way that I know if I'm in that position like I was as the CEO of a health system, and I had my own insured population, which were, the 30,000 people that I was financially responsible for. I had to know who I needed to reach out to, who would have an impact from an outreach, and who would be responsive. And that's part of what tools like Prealize's machine learning algorithms do. And I don't know how I don't know how you live without them.
Ron, I'm reminded that historically medicine started out as a sort of a social enterprise, and then became a more scientifically based disease treatment career or enterprise. And then over the last 75 to 90 years evolved to a prevention and risk mitigation enterprise. So an awful lot of those diseases of the prior centuries, we don't even see anymore, thanks to vaccination and public health interventions. But risk mitigation with limited resources demands focus and attention on a reliable subset in order to be effective, always watching outcomes metrics to be sure that something new isn't occurring. And so I fundamentally agree that sophisticated prediction is at the heart of efficient resources utilization when it comes to risk mitigation.
So let me pile on here and in the process answer a question that Brandon asked. If you're a health plan, look, health plans have been trying probably for a couple of decades now to get closer to their patients, to get their patients to engage, to reach out with care management strategies, with other strategies to do the kind of risk mitigation that Gordon was talking about, with frankly, not all that great success, to be candid. And now health plans are joined by provider groups like ACOs, capitated medical groups, MA plans, and others who also are risk-bearing and are in the get out in front of the disease business for both clinical and economic reasons. The three diseases that we talked about in this report, cancer, musculoskeletal, and heart disease, in the case of cancer and in the case of heart disease, as we've talked about before, you're not going to be able to reach out to everybody. And so you need to be able to figure out, as Ron said, who are the people who are at greatest risk? Who are the people who need to be really gang tackled in terms of pouring what resources you have at them to get them in, to get them screened, to make sure if there's a problem, it's taken care of early. In the musculoskeletal case, it may be less about, although fractures is one, it may be less about screening and more about direction to the right place. So Hip replacements have been deferred. Knee replacements have been deferred. People's knees don't generally get better by themselves if they're bad enough to need a knee replacement. So the question is not do they need a knee replacement, but where should they get it? And plans have different strategies with regard to centers of excellence and all sorts of tiered networks, but this is the time to figure out how to reach out proactively to those people who may have deferred a knee replacement or a hip replacement or a shoulder replacement that's coming, and engage them in whatever steerage strategy the plan has developed or the capitated group has developed to try to make sure that they're going to get the highest quality at the best cost. So in all three of those cases, I think there are use cases for a predictive approach to try to target one's resources, since they are expensive and frankly not universally effective. Let's direct them towards the people where they'll have the most impact.
There's a question from Michael B. Where do you see the biggest risks and opportunities in terms of cost and conditions in both the near term 2021 and longer term 2022 and beyond? Of course, we mentioned cancer, heart disease, and fractures, but want to hear more about that. Biggest risks and opportunities, 2021 and beyond.
Well, I'll say I think the biggest risk is this also the biggest opportunity and the biggest challenge, and that's mental health. Let's remember how many millions of people have lost their jobs, their livelihoods, their businesses. They may not be coming back sometime soon. And so in addition to the kind of straightforward baseline of mental health issues whose treatment may have been deferred, I don't think we know yet what state the country will be in a year or two from now. It's been a turbulent year. I'm glad to get up and not hear from the president every morning, frankly. It's been a turbulent year for lots of people in lots of places, and lots of people's lives have been affected economically, even if not medically, by the pandemic. So I think that's going to be a big challenge, a big opportunity, a big place for us to do more.
I think it's a good point, Mark. Short of outright depression and PTSD type syndromes, I'm concerned about a diffuse level of high and maybe even debilitating dysphoria that a lot of my contacts, friends and family have been going through. It hasn't got them absolutely glued to the couch yet, but their interest in pursuing even the available limited activities that we have right now with all the lockdowns, et cetera, is waning. And will herd immunity bring that back to baseline? I'm somewhat skeptical about that. So how do we deal with national dysphoria in the wake of a pandemic?
Yeah, and I would add, I agree with both of those points. And I was going to say, originally, it's the intersection of mental health plus those diseases. Because we know that mental health has an impact on cardiovascular disease, it has an impact on other diseases, and we also look at the prevalence of substance abuse during the pandemic, right? So alcohol consumption has gone through the roof, that's easily measured. Every state and its sister is legalizing cannabis, right? So without judging on it, I'm just saying, the amount of abuse that has been occurring with everybody locked in their homes is something that we don't have our arms around yet, and is going to manifest itself because those behaviors, smoking, alcohol, are associated with cancer, COPD, heart disease, CHF, right? It's a vicious circle.
And the opioid epidemic has not gone away. Hundreds of people have died of fentanyl overdoses in San Francisco in the last year. Not gone away. And because so much of our substance abuse treatment for a variety of reasons depends on in-person, person-to-person contact, there are a lot of issues there. So I think that's another place where people can innovate care models and can also do some predictions about people who will need special attention, reaching out, trying to make sure that they stay in treatment or get back into treatment.
Okay. If mental health is one of the largest risks and opportunities, what types of interventions should health plans and systems be planning?
Well, I'll start. I think it begins with efficient means of screening using existing modalities of communication, existing short screening questionnaires and other validated surveys, and deployment of available and appropriately trained resources, all of which exist in a limited capacity in most practices and delivery systems and health plans. So you're not going to turn your entire health plan case management department over to doing this, but you probably have to segment out a subset of folks to be focused on this and coordinating at the same time with providers and delivery systems to avoid duplication of effort.
Yeah, and I think it's the things we've talked about relative to virtual care. There are lots of opportunities for virtual mental health care, both from a telehealth interaction, but also a number of cognitive behavioral therapy based apps and related services. But I'll tell you, just anecdotally, careful with the interpretation, I recently tried to facilitate a CBT relationship for a person in the Los Angeles area that was willing to pay full price cash and have not been able to find a therapist taking any patients.
Yeah, I think that's right. So everything I've ever read suggests that if you screen for even mild depression, you will find a lot of it. And I think a lot of times providers don't do it, just as they don't screen for food insecurity because they're concerned, well, what am I going to do about it if I find it? And so I think it is worth pointing out there has been this explosion of virtual behavioral health, which is ironic because before the pandemic, we were just beginning to see innovations of co-location of primary care and behavioral health in the bricks and mortar world. And now that the bricks and mortar world has gone away for a while, I think there's a big challenge to figure out who can be helped by the various levels of telehealth, human, computerized, automated that are available. So that kind of triage of figuring out severity and who can be helped by what is going to be an important thing because there aren't enough humans. Even if, as Ron pointed out, even if you pay them cash, there aren't enough humans to make a significant dent in the demand. So we're going to have to use new modalities. And I think it's going to be important for us to figure out who can be helped by what kinds of modalities. And that work is beginning now.
I know we're at some risk of perhaps oversimplifying that digital doctor will take over all these problems and be sufficient by itself. But I do think that the advances made in virtual health, telehealth, et cetera, partly spawned by the pandemic, but with roots that were earlier, will help us move from co-location of behavioral and physical health to collaboration among those who can address the whole person in an integrated fashion.
Yeah, and that was sort of Mark's earlier point around hybrid practices, right? We've always known that it's what patients or consumers or people, whatever your language preference is, do 99.9% of the time outside of a doctor's office or facility, right? So there was never a possibility of sort of supporting and engaging at the level that we need to and hopefully want to do to mitigate and prevent illness if it's all going to be within a bricks and mortar facility. Not going to happen, right? So there may still need to be the need for co-location of behavioral health within a clinically integrated group practice, but it doesn't end there. It also needs to extend out. And if you don't do that virtually, I don't know how the hell you do it.
Yep. Let's see. So I'm looking here. So how can Prealize directly impact the three key trends: cancer, musculoskeletal, and heart disease mentioned in the white paper? Are there specific use cases that you can share? I'll let you all take a stab at that before I add my thoughts.
Hey, that sounds like a question for you.
Yeah, I tried to do that conceptually the last time I spoke, but I'll leave the use cases to you.
Yeah, well, and even BH, you know, behavioral health is a really key thing for our customers. But, you know, being able to, we like to call it peek around the corner and see down that long haul of 12 to 18 months in advance, but to provide the level of explainability that all of our models give, it gives that next level of detail to understand, you know, sort of the why, so that one can connect it to the right level of action. Whether that is prioritized care management outreach, connecting to one of the many programs that payers have you know, instigated. It could be a behavioral health provider. It could be steerage, as you talked about, Mark, you know, in terms of their high value musculoskeletal providers. If it's a knee surgery, hip surgery, we've had, you know, customers who have programs where they literally, you know, move the patient to that higher value center because they know that they get higher quality, better outcomes for the patient, and it also is lower cost. So giving those level of insights before those things occur, before a diagnosis hits, before a claim is filed, you know, whether it's in the coding gap or the diagnosis gap, is what machine learning is all about. And you all have really made a good point about that continuous learning, because we're in atypical utilization, because the machine can see things that we cannot see. It's so important for our customers to be able to have that level of proactive insight with the level of detail at a member level specific to their population in order to drive that kind of outreach prioritized with skinny resources.
Linda, let me add on. When I first became very familiar with predictive models early in my health plan career, I did a bake-off of the dozen or so leading predictive models at the time and found remarkable similarity or clustering in their predictive accuracy measured by PPV for highest risk subgroups. Then along came AI, which appeared to add significantly to that. But then again, AI is not AI. We now know that many other models that attempt to use machine learning or AI methods don't necessarily achieve the same predictive outcomes and positive predictive value. When you're able to achieve PPVs of 70 to 90%, and the most work you do, it makes an enormous difference in terms of return on investment for using those predictive models. You're not wasting your time doing outreach and phone calls and interventions to false positives as much as you are true positives. So I think that's an important consideration for those on the call.
Right. You know, so one of the things that I think, as we think about the last 2 minutes here, maybe quick comment from each of you. I often attend webinars. Folks here on the phone and on the video will come away with all kinds of great ideas, but activating them when they get back home or when they get back on the Zoom with the rest of their organizations is really difficult. So what can folks do as they leave here to create some urgency in their organizations about activating a lot of these great ideas and advice that you've given?
I would suggest that those who have the interest immediately identify, you know, credible, candid connections they have at middle to senior leadership level and inquire what are the plans for dealing with what's coming with this backlash on the deferred care. How are we approaching it? What are we doing for outreach of high-risk folks who may not be coming in? How are we collaborating with all of our health plans? What are we doing to leverage the EHR portals that we have available to our patient panels? I think those are all relevant questions that could start the ball rolling.
I think that's a great suggestion. I also think it's time for everybody to say, what exactly are our connections to our local health department? Because like it or not, they're going to be the fulcrum for a lot of the case finding, for a lot of the vaccinations. And I think we're not going to get this done without a much greater level of collaboration between what have been private medical providers and private health plans and public health authorities that will have the responsibility of getting this done. So I think that's also a pretty urgent thing that people can do.
Not much to add. I'll just say, emphasizing the earlier points, ask, listen, educate. There's a message in the chat, download the report if you haven't seen it. That's just one example of what can be done. And these issues are there. So you're going to need a solution.
Great. Thank you so much. I'd like to thank you, panelists, for your engaging dialogue and active participation. Thank you to the audience and participants for listening, submitting so many great questions. Thank you for joining. We look forward to seeing you all at future events. Signing off.
Take care.
Thank you.